initiated study run by Francois Fenter up in Joburg. And this study looked at just over 1,000 participants randomized to 3 arms. The bottom green arm was the standard of care, which is tenofovir and efavirenz, with emtricitabine, which is abbreviated as FTC. And then they compared them with 2 dolutegravir arms. The one was using TAF, which is a newer formulation of tenofovir, which has got some safety benefits. And so they wanted to see, was dolutegravir non-inferior to efavirenz, and what about TAF? Or should we be switching to TAF? They recently published their 96-week results, and they did show quite striking differences in weight gain by sex. Women gained a lot more weight than men. The TAF arm, which is in red, gained the most weight, and the dolutegravir arm versus the efavirenz arm gained somewhat more weight, and that was the same was true for both men and women, but the effect seemed to be more striking amongst women. Not going down, don't know why. Here we are. Okay. So the key questions with this dolutegravir associated weight gain: is dolutegravir producing off-target effects on either appetite or metabolism? Or an alternative hypothesis is that the comparator drugs might be impairing weight gain. We did a study which was done by Roland Crissel, who's registered for a PhD with us, and the PI was Pumla Sinkadi from our division, who's got a special interest in pharmacogenomics. And SIP2B6, which is one of the P450
email, Gary is presenting on dolutegravir
enzymes.
If you're keen to listen.
Pumla, you're muted. You're unmuted, I mean.
Oh, Gary, do you mind just unmuting yourself again? Sorry, I muted everybody.
Okay, sorry. Where did I heard Pumla, and I think I might have muted myself by mistake.
No, that's all right. Please go ahead.
Okay, so the background is that the cytochrome P450 enzyme SIP2B6 metabolizes efavirenz, and about 20% of South Africans have genotypes that impair the ability of this enzyme to metabolize it. There was an observational study from the States suggesting that people who switch from efavirenz to integrase inhibitors gained more weight if, while they were on efavirenz, they were slow metabolizers. And there are several potential mechanisms for this. Firstly, efavirenz has concentration-dependent toxicity to mitochondria and adipocytes. Second, there's less lymphat gain with efavirenz compared with the PIs. And third, the chronic neuropsychiatric toxicity, which could result from the higher concentrations in slow metabolizers, could have some effects on appetite. So our hypothesis was very much that efavirenz might be impairing weight gain. So that's our hypothesis, was that these SNPs could impair weight gain in people living with AIDS and could explain the observed differences between efavirenz and dolutegravir. So I've shown you the study before, but for this study, we collaborated with the advanced team. We only looked at the efavirenz and dolutegravir arms where the NRTIs were the same, TDF and FTC, and only some of the people in the efavirenz arm consented to genotyping. We had their weight measures and their regional fat distribution by DEXA out to 48 weeks. Here's the bottom line results of weight change. What you can see is that people who were wild type SIP2B6 gained the same amount of weight as the dolutegravir arm, whereas people who were intermediate metabolizers or slow metabolizers gained less weight, and it was a striking dose-response relationship. When we looked at regional fat, there was sex differences. Amongst men, there was no difference in in limb fat, which is a proxy for subcutaneous adipose tissue, whereas in women, slow metabolizers lost a little bit of weight, intermediate gained a bit, and wild type gained somewhat more. So there were differences in regional fat distribution, which was largely subcutaneous adipose tissue. Visceral fat was similar between the sexes. There was a trend perhaps of the same dose response amongst women, but that did not reach statistical significance. So returning to that study of the 8 RCTs, I wanted to show you their 2 other comparisons. I've shown you already that integrase inhibitors gain more weight than other classes. But here is a study of rilpivirine, which is a new NNRTI, compared with efavirenz, and you can see there's a lot more weight gain with rilpivirine than efavirenz. And in the bottom graph, these are 4 different NRTIs. And TAF, which is the one that was associated with the most weight gain in the advanced study, gained more weight than abacavir, which in turn gained more weight than TDF, which is the old tenofovir formulation, which in turn gained more weight than zidovudine. And if you were to run assays of mitochondrial toxicity or other forms of metabolic toxicity, you would see exactly the same kind of ranking. So revisiting the questions of weight gain, it's biologically implausible that we are seeing off-target effects on appetite or metabolism from integrase inhibitors, rilpivirine, TAF, or indeed each of the individual NRTIs separately. It is much more plausible that the older, more toxic antiretrovirals, especially those that are associated with metabolic toxicity, are in fact impairing weight gain. The newer ARVs are less toxic, allowing a better return to health phenomenon. We could do a lot of harm by telling people that their dolutegravir is causing them to gain weight. It could impair adherence, it could result in inappropriate switching to more toxic older drugs. My final slide relates to the question of health. How can we talk about health when we are talking about people becoming obese on therapy? Well, this is an analysis by Andrew Carr of the advanced study data. This is men and women. In the beginning is the baseline BMI, and then after 144 weeks in this analysis. The last 2 bars are population surveys by the WHO in the SA-NHANES study. And men have a mean BMI of just under 25 in South Africa. And what you can see is that the dolutegravir TAF arm is almost there, TDF arm not quite, the efavirenz arm dropping somewhat behind. And a similar story for women whose BMI is just under 30 in average population. And the same sort of dose response, efavirenz somewhat less, dolutegravir a little bit more, and dolutegravir and TAF greater still. So health doesn't necessarily mean returning to an ideal BMI, but it does mean returning to what the average population, and that after all is what we're really after. We want to take HIV positive people, treat them so that they can become normal in all senses of the word. And if that means being overweight, then so be it. Thank you.
Thank you very much, Gary, for that fantastic overview of integrase inhibitors, and in particular, the biology and side effects of dolutegravir. My first question for you, Gary, is whether you think that this is the neurotoxicity is a class effect, or is it specific to dolutegravir? Hi, Gary. I think you may be on mute.
Sorry, I've been continually doing that through the talk. There isn't enough information on the other integrase inhibitors. Dolutegravir is the one about which we have most information. Botswana switched to dolutegravir ahead of other African countries. Other registries that have a few people with integrase inhibitors have not seen a signal with any of them. So for now, we're not certain about it, but we know that dolutegravir has this biologically plausible action on the folate receptor, which could explain the toxicity.
My second question for you, Gary, is what would your comment be on the observation that with increasing sample size and the calculation, the prevalence of neural tube defects in pregnancy seem to be declining, though still are clearly higher than other ARVs? And what is the key message around how clinicians should think of using it in young women with HIV, many of whom are of childbearing age?
Okay, so here's my first slide, where what you can see here is the confidence intervals are very wide. And I think it's just a question of precision. When you make an observation based on small numbers of events and a relatively small sample size, you have wide confidence intervals. And the confidence intervals in subsequent studies somewhat overlap with those that were seen initially, but the confidence intervals have just become tighter. So it's purely just a phenomenon of sample size and precision improving with bigger sample size occurring over time. This data has been very carefully reviewed by the WHO and by SAHPRA and by the National Essential Medicines List Committee. And we decided that there did seem to be a risk. It was somewhat lower. And provided a woman are after the neural tube has closed, which is about 6 to 8 weeks, we are quite happy using dolutegravir in pregnancy. And we have informed women, the policy is to inform all women that if they want to fall pregnant, they should not fall pregnant on this drug. If they do fall pregnant on the drug, ideally they should be offered high quality ultrasound to see if there is a neural tube defect. So that's our current national policy.
Incredibly helpful, Gary. There's a hand from 01337742. I think that's Ian from previous meetings. Please go ahead, Ian.
Thank you very much. I don't know exactly how to change it, but some of the IT fellows might be able to change it for me. But Gary, I wanted to thank you for an excellent talk. But I guess my question is the presumption that the weight gain is non-metabolically active? Have there been, for example, evaluations of dysglycemia or aberrant triglyceride levels in these patients to show that, or at least to attempt to show that it is non-metabolically active?
Okay, so in the interest of time, I didn't go there, but in the advanced study, they have done a whole battery of measures, glucose, lipids, HbA1c. They measured a raft of hormones like leptin and other adipokines. It seems that, like general obesity, there are some consequences. Interestingly, the efavirenz group, which gained the least weight, had slightly higher increases in fasting glucose. And there are some lipid changes that are associated with efavirenz that aren't seen with dolutegravir. So it's hard to tease out. I don't think one can say that the weight change on starting ART is not associated with any metabolic effects. I think it is. And certainly as people move to higher and higher BMIs, there will be risk factors associated with it.
Thank you, Gary. That's most helpful.
Thank you very much, Gary. That was an excellent overview. I really enjoyed that and masterly delivered. So I'd like to invite our next speaker, Dr. Nordien, who's speaking on behalf of the Division of Endocrinology, to upload her slides.
Hi, I'm trying. Here we go.
Fantastic. Please go ahead, Rosie.
Sure, got it. Okay. Hi, thank you very much. I'd like to present a
Rosie, you seem to be muted.
Oh, sorry. Okay.
Wonderful. Can you hear you now?
Oh, can you? It looks like it's the internet. Okay. All right. So the patient is 75-year-old Mrs. SC from Friedenberg, presented initially to Somerset Hospital. She had a 1-week history of nausea, vomiting, visual disturbances. The family described that she had sort of almost like a tunnel vision, intermittent confusion over that previous week. On assessment at Somerset, she was severely obtunded with a GCS of 9 out of 15. This prompted blood tests and further investigations. This was also on the background of a history of having hypothyroidism and questionable compliance. Her blood results showed a sodium of 107, a very high TSH of 42, and a T4, which was very low at 4. Urinary electrolytes were done. She had a urinary sodium, which was 40, which is notably inappropriately high for the degree of hyponatremia. And imaging done at Somerset revealed that CT brain showed a supracellular mass consistent with a pituitary macroadenoma, which was just over 32 by 46 millimeters. Although having a sensitivity of over 88%, depending on the study that you look at. So management, she received stress doses for hydrocortisone at Somerset Hospital, 100 milligrams IV 8 hourly, and no thyroid replacement that was commenced at that stage, probably because of the fear of precipitating an adrenal crisis. And although, unfortunately, it looked like, I'll show you the laboratory tests now, the cortisol level was quite high. This was actually done already once they had initiated hydrocortisone therapy. So we were unable to actually confirm secondary hypoadrenalism, as hydrocortisone is actually measured as cortisol in our lab. Looking at the laboratory investigations, you can see the profoundly low sodium of 107, which showed prompt normalization after the initiation of hydrocortisone. Normal renal function, calcium, magnesium phosphate, the serum osmolality is normal. And then looking at the thyroid function, the TSH initially of 42 and the T4 of 4. Then she was transferred to Frederick's Hospital and seen in neurosurgical ICU. She still had a GCS of 13, and although much improved from 9, still remained somewhat confused. And you can
Rosie, we seem to be losing you again.
Oh, sorry. I think it's the internet. I think it's the internet. Let me just. Can you hear me now?
Yeah, we can hear you. Go ahead.
Okay. All right. So yeah, so MRI confirmed no apoplexy. Endocrine was then consulted on the 29th of October, and the diagnosis of a pituitary macroadenoma was made, but primary hypothyroidism, which was complicated by myxedema. She was managed with a stat dosage of altroxin, and then as well as daily altroxin, and T3 was replaced, 10 micrograms 8 hourly. Hydrocortisone was continued at stress doses, and there was an improvement in GCS, the hyponatremia resolved, and hypothyroidism started to improve, but she still remained confused. And this was, she was, although orientated for person, not for place or time, and was quite disorganized in speech. In the period of time, she also became transiently polyuric, and I'll address that after I just give you a summary of her examination. So her vitals were normal. She wasn't bradycardic. Neither did she have any diastolic hypertension. She was oxygenating well and had a normal gas at that stage. She was a bit drowsy but arousable, and as I said, disorganized speech. The content of her speech involved a lot of banoffee pie and her rose garden, but beyond that, nothing much else could be understood. She had coarse, dry hair, a puffy face, and very obvious periorbital puffiness. Unremarkable thyroid examination, and she did have a complete cranial 3 palsy on the right. We were unfortunately unable to formally assess visual fields, but she was grossly neurologically intact except for that cranial nerve. Cardiac, pulmonary, and abdominal examination were unremarkable. So just looking at further abnormalities in the laboratory, in the bloods, we can see that she had a normal prolactin. FSH and LH were markedly suppressed for somebody who was postmenopausal. Growth hormone very low, and insulin-like growth factors also low. The urine osmolality, as you can see, there was 536, and urinary sodium 48. Right, so in terms of the discussion, the question was whether this was primary or secondary hypothyroidism. It's believed to be primary in the fact that her TSH was markedly elevated in the 40s, mid-40s, and a profoundly very low T4. In secondary hypothyroidism, often patients maintain a normal or low TSH, and if they do have a raised TSH, it's under 10. And often the TSH is non-glycosylated and not metabolically active. So that's why we diagnosed her with primary hypothyroidism in this setting. And also her T4 being extremely low, usually with central or secondary hypothyroidism, patients the thyroid remains somewhat autonomous and still produces some T4 even in the absence of TSH stimulation. And also the diagnosis of myxedema favors the fact that this is more primary. And then features looking at myxedema, what primary. The prolonged confusion, even though her sodium had corrected, suggests the myxedematous coma, which was now resolving. As my internet, is it okay still?
Yeah. It keeps on cutting, Rose. Are you in the hospital?
I am, yes.
To log into your EduRoam network.
I am on EduRoam. Oh. Yeah, I am. Let me just, I'll walk out into the passage. Maybe it's a bit better, yeah. Okay, can you hear me?
Yeah, we can hear you.
Okay. Okay, and then the confusion from myxedema can go on for well over 4 to 6 weeks before the patient recovers completely. Okay, and then the obvious clinical findings, features that she had of hypothyroidism was also clinically evident. The hyponatremia that she had could also have been secondary to the myxedematous state because of the increase in ADH associated with myxedema. Okay, so then in looking at management, the initial management of myxedema is intravenous, either T4 and T3, and then followed by oral replacement once the patient is more awake. Hydrocortisone is administered until you can exclude the fact the patient has hypoadrenalism. And then obviously in more severe cases, patients may require ventilation, intravenous fluids, passive warming if they're hypothermic, and often they can become hypoglycemic, requiring dextrose infusions. And if you assume that there's an underlying precipitating event, being infection or sepsis, you can consider empirical antibiotics. The administration of T4 and T3 can precipitate cardiac myocardial infarctions and atrial arrhythmias, but that risk is, we have to accept that risk in the face that the mortality associated with myxedema is greater. So patients just need careful monitoring. And then prognosis, depending on the study you look at, mortality rate can range anywhere between 30 and 60. And factors associated with poorer prognosis include advanced age, persistent hypothermia, and bradycardia. And then looking at the polyuria, it was interesting to know that there's an inverse relationship between antidiuretic hormone, cortisol, as well as antidiuretic hormone and thyroid. So in this case, she was assumed to have secondary hypoadrenalism, so low cortisol levels, as well as profound hypothyroidism, both resulting in an SI-ADH, causing the severe hyponatremia and the prompt correction of its following the thyroid and hydrocortisone replacement. We obviously looked at other causes of SI-ADH, such as thiazide diuretics, whether she had antibiotics, antidepressants, or any other anti-epileptics. None of those were, she wasn't taking any of those medications. So just in summary, a very unusual case to see mixed edema, first of all. And secondly, it doesn't occur in the setting of a pituitary macroadenoma, which is why we said that she has most likely got a primary hypothyroidism in addition to this pituitary macroadenoma. Could it have been incidental? Possibly, but the fact that she had the cranial 3 is unlikely, and she might probably manifesting symptoms prior to this presentation. A learning point, mixed edema, very high mortality rate and requires prompt treatment, as well as the replacement of the hydrocortisone being critical to avoid any adrenal crisis, and that hypothyroidism can result in hyponatremia. And yeah, and that we just need to be aware of the poor prognosis and requirements of prompt treatment. Yeah, that's it.
Thank you very much, Rosie,
Sure.
for that talk. I'm sorry about the technological challenges, but I think the message came through clearly. Ian, would you like to make any comments?
Thank you very much, Ntobeko. Thank you, Rosie, for a superb presentation. I think you've highlighted most of the important discussion points and outlined how this patient actually, the natural history and the clinical course progressed. But I just wanted to emphasize it really is unusual to find the coexistence of mixed edema with a pituitary macroadenoma. And I think what alerted us to this problem was a very elevated TSH. The other thing is, in both instances, were it to be primary hypothyroidism or secondary hypothyroidism, in the subtunded state in both conditions, hopefully the clinicians would be alerted to the fact that prompt administration of hydrocortisone is really of paramount importance. And you can actually see how promptly her sodium responded on the basis of recovery, on the basis of administration of the sodium, which is really quite gratifying. And the other important thing that one has to bear in mind is when one replaces thyroid hormone, one should first do it, first replace the hydrocortisone, and then only then, after one is satisfied that one has given supraphysiological doses, then only administer thyroxine. I think you've highlighted the most important considerations in both these cases, representing high mortality rates associated with both of them. So I think overall, unusual, but as separate entities, we will encounter them regularly. And most clinicians on the G floor will encounter mixed edema from time to time. And every so now and again, they will encounter a pituitary macroadenoma who has presented with hyperpituitarism and hypoadrenalism. So those are really my points. And just to bear in mind the importance of supplementing the hydrocortisone for at least 24 to 48 hours prior to administering thyroxine.
Thanks very much, Ian, for those comments. There's a question from Deb Blom around the patient's serum lipids. And perhaps I can ask if you can answer that question in light of the approach one takes to differentiating between primary and secondary hypothyroidism, and also give us some understanding of the differences in lipids between the two. Thanks.
Hi, I can actually say we did actually only realize when I was preparing the presentation that the patient hadn't actually had a lipogram done, which is obviously important in the setting of the, the sodium and the thyroidism. But so unfortunately, we don't have the lipid profile on her. But that is an important point that we did realize a little bit too late. I don't know if Prof wants to say anything else.
Okay, so just to bear in mind, your question was relative to the lipids of the, if I'm understanding you correctly, does primary and secondary hypothyroidism have a different manifestation? Is that the question, Ntobeko?
Correct.
Well, I think how I would best like to answer this is that, the severity of secondary hypothyroidism is modest at best. So, the classical texts say that the severity of lipid abnormalities, because they are only modestly deranged, do not manifest with the severity of the lipogram or abnormalities that one encounters with profound hypothyroidism. And I'm sure it's a function of the severity. Now, you'll encounter a whole host of abnormalities, and I'm sure Dirk would like to speak to that. But by and large, the lipogram is only modestly aberrant in secondary hypothyroidism.
Wonderful. Are there any questions for Rosie? Well, if not, thank you very much, Rosie, for that presentation. And sorry about the poor signal from the Wi-Fi. I'd like us to move to our third and final presentation for the day, which will be a double act from A Singh and E Boesak, who will speak on the Ambition trial. Please go ahead, Emmanuel. Rosie, would you like to unshare your screen, please?
Good afternoon, everyone. I'm just waiting on Akita to upload our slides first.
Emmanuel, do you mind speaking up? Your volume is very low.
Sorry, can you hear me better now?
Much better, thank you.
All right, I'm just waiting for Akita to upload our slides.
Sorry, Manny, I can't yet share my screen while another participant is sharing. So I'm just waiting for that. Hang on a moment, Manny.
That's fine. I'm Dr. Emmanuel Boesak. I'm a medical officer in internal medicine at Mitchell's Brain, and Dr.
Just hold on a second, Emmanuel. Let's just see if Ashita can put up the slides. Rosie, have you unshared your slides?
I have, yeah.
Okay.
Go ahead, Ashita.
Okay. Let's see. Can you see my screen?
No, we can see you.
Oh. No.
So it's
sorry.
The one arrow pointing up that says share screen.
No. Yeah. Gosh.
I can share now.
I wonder, does Graham have your presentation? Maybe he can upload it for you.
I should be able to. Just give me one moment. I don't know.
Oh, there we go.
Right.
Fantastic. And would you like to go to presenter mode?
Oh, there we go. I'll be able to share.
Are you sharing, Akita? Can't see it.
There we go.
All right, there we go. All right.
Okay, cool. Sorry about that. There we go. Fine?
Success. Please go
Great.
ahead.
Yeah. Good afternoon, everyone. I'm Dr. E Boesak. I'm a medical officer in internal medicine at Maartens Hospital. And Dr. Akita Singh is one of the medical officers working in collaboration with the Outpatient cryptococcal meningitis trial. And we will be presenting a case of recurrent cryptococcal meningitis titled Hercules and Hydra. And you'll see throughout the slideshow why this has relevance pertaining to the Hercules and Hydra Greek mythology. I'll ask Akita to then go forth and with our slideshow. Akita?
Okay, Manny, can I mute you for a second? No.
That's fine.
Okay, cool. Right, so the Ambition cryptococcal meningitis trial is a multi-center clinical trial running throughout Africa. We are currently on 802 participants out of 850, so we're nearing enrollment. I mean, we're nearing full enrollment. So the Cape Town sites take place in Mitchells Plain District Hospital and Khayelitsha hospitals. And the trial compares a single high dose of liposomal amphotericin B in combination with 2 oral medications as an alternative induction phase with the current World Health Organization standard of care, which is also our standard of care in the Western Cape. The primary endpoint of the trial is all-cause mortality within 10 weeks. So that is the Ambition trial. I'm trying to progress. So we are presenting a case that Manny and myself were involved with. She's a 28-year-old female who was admitted to Mitchells Plain Hospital in June. She presented with 2 weeks of headache, fever, photophobia, neck pain, loss of appetite, and loss of weight. She is an ART experienced patient of 5 years duration on tenofovir, emtricitabine, and efavirenz. And she had disengaged for about 5 months prior to presentation. She is known with advanced HIV, but this was diagnosed on this admission with a CD4 count of 18. She had had no previous opportunistic infections prior to this presentation. So the patient is a well-informed patient. My impression of her was that she was quite well-informed about her HIV. Previously employed, the issue with the ART disengagement was due to relocation between provinces and a lack of a transfer letter, sadly. She also had some elements of treatment fatigue, and then her protective factors is that she had a supportive family. So on clinical examination, she was generally unwell. She was ambulant, but she had an ECOG score of 3, which is a functional scoring system, and basically indicating that she was in bed about 50% of the day, but up and about the rest of the time and unable to work. There was meningism present, no focal neurology. And on day 1 of the trial, we do a visual acuity on the logMAR scale, and her eyes showed a moderate impairment. Admission bloods, or rather, should I say, trial day 1 bloods, and showed a hyponatremia of 118, a pretty modest electrolyte abnormalities, a potassium of 3.1, which is a grade 1, grade 2 DAIDS defined hypomagnesemia of 0.48, and a baseline grade 2 anemia of 8.2 grams per deciliter. So that was her bloods. And then in terms of the CSF, she had a raised protein on her CSF and a lymphocytic predominant meningitis. Yeasts were observed, and then it became a diagnostic CSF when this cryptococcal antigen came back positive, confirming that she had cryptococcal meningitis. It was culture positive as well, and there was no TB on Gene Expert and culture that came out later. Okay, so in hospital treatment, she had her induction phase antifungal treatment. So she was treated with amphotericin, flucytosine, and fluconazole. And she was also treated with lumbar punctures. She required 5 therapeutic lumbar punctures on 9 days. So day 1 and day 7 were scheduled study taps, and then day 4 and day 5 and day 8 were therapeutic driven. If you see there, her peak opening pressure was only ever 20 centimeters of water, and that's not very high, but she was very symptomatic. Her symptoms were nausea, vomiting, and headache. And they said those symptoms settled so quickly once you would tap her initially, and then later on in the admission, she'd have a slower response, but still a very good response to pressure management. And she had a good treatment response overall. Her in-hospital course, her hyponatremia improved to sort of 130. Minor potassium and magnesium abnormalities improved on routine oral supplementation. She displayed no major toxicities to the antifungals, and the vomiting was managed quite well with LPs and metoclopramide. We did pick up that she had an acute cystitis, cultured E. coli, and was treated with ciprofloxacin and cleared. And then she was discharged home on the 12th of June for routine trial follow-up. So as an outpatient, she settled quite well. She needed 1 therapeutic tap, I think, the day after admission. And then she had a scheduled study tap on day 14 with normal pressure there. And that cleared, that CSF had cleared. The ART choice that we chose for her was tenofovir, lamivudine, and dolutegravir, which we initiated at week 4. This was well tolerated, and she had very good adherence. She also had very good adherence to 800 milligrams fluconazole daily, for which she was on consolidation phase for 2 months. She also had good adherence to cotrimoxazole prophylaxis. So at our last visit with her on the week 10, we were quite happy with her. Her vision had pretty much normalized, and we switched her down to 200 milligrams fluconazole prophylaxis or maintenance therapy as per the Western Cape guidelines and the trial guidelines. And we referred her out to her clinic, not really expecting to see her again. But unfortunately, in week 11, Hydra struck back. And Manny is going to tell you a bit more about the readmission here.
All right. Can you hear me, Akita? Did you unmute me?
I can hear you.
Okay.
Can hear you.
Right. So the patient represented to us about a week after starting a maintenance treatment of fluconazole 200 milligrams. So on readmission, she had headache, fever, vomiting. Of note, she had worsening visual disturbances on this admission. Clinically, she had meningism. Level of consciousness was not altered though, and she had no lateralizing signs. Keep the next slide, please. Okay, so this is just a table that represents her CSF index and CSF findings when she was readmitted to us. We did lumbar punctures on the first 3 days, and of note, the findings were she had a low glucose CSF, mildly raised protein on all 3 of her lumbar punctures. She had a lymphocytic pleocytosis on her CSF cell count, and on all 3 of the lumbar punctures, these were observed. The CSF cryptococcal antigen was positive, but that was unexpected as she had recently been treated for cryptococcal meningoencephalitis. The prolonged culture, fungal culture, which only came out 2 weeks later, was positive for cryptococcal neoformans 3 times, and again a TB diagnostics was negative all 3 times, gene expert and tuberculosis, microbacterial tuberculosis cultures were negative. Next slide, please, Akita. So we had a bit of a diagnostic dilemma with the patient. We were struggling whether or not she had a cryptococcal meningoencephalitis relapse, or was it a cryptococcal meningoencephalitis immune reconstitution inflammatory syndrome. And then obviously with a low CD4 count at base, one had to consider other opportunistic infections like toxoplasmosis, CNS tuberculosis, and other opportunistic infections. We did some bloods, lumbar puncture, as I showed on the previous slide, CT brain, which showed no space occupying lesions. But essentially, the this current admission, basically she fit the definition for symptomatic relapse because she had previous laboratory confirmed episode of cryptococcal meningitis on CSF, which was seen on her first admission. She reported adherence, and the one thing that we can also objectively say is that she was adherent as a trial nurse and was following up with her. And then on this admission, she had recurrence of typical cryptococcal meningitis symptoms, and essentially we had proof of cryptococcal organism on culture of CSF prolonged culture. And what finally to say that there was no alternative diagnosis, there was no evidence of TB or any other opportunistic infection. So her in-hospital course stay on the second admission was a bit different to the first one. She had persistently elevated pressures, and a peak opening pressure was at 50 centimeters of water. We discussed with infectious diseases, and the consensus was then to treat her as per conventional Western Cape guidelines with amphotericin B and susceptibility for a week, followed by fluconazole high dose for 1 week. In a 10-day admission, she required 7 taps for relief of symptoms. We did not need to start on steroids, and we did not need to discontinue ART as she didn't have any life-threatening symptoms. She maintained a level of consciousness, and there was no focalizing signs. Both of the first isolates and the second set of isolates were sent away to the NICD for further sensitivities and culture. And the last thing of note on this admission is that she did have a mildly raised creatinine, which was not double her baseline creatinine, so we continued with amphotericin B. She peaked at a creatinine of 127. I'm just going to hand back to Kita to continue with the NICD slides.
Okay, thanks, Manny. So the NICD isolate one that's here was the index cryptococcal meningitis CSF, and then so we sent off basically 2 isolates. Isolate 1 was from the index admission, and isolate 2 was from the relapse admission. So if we look at NICD isolate 1, you'll see that if you look at fluconazole, the MIC minimum inhibitory concentration is 8 micrograms per mil, and it is Cryptococcus neoformans species complex. And the NICD isolate 2 from the relapse admission is Cryptococcus neoformans species complex, and the MIC for fluconazole is also 8. So this was quite interesting for us. So we realized that if you use the MICs to sort of categorize this patient or this CSF and this resistance, it's actually susceptible because she fits in with the definition of an MIC of 8. Other categories are dose-dependent susceptibility, which is typically an MIC of between 16 and 32 milligrams per mil. And then resistant would be an MIC of 64 micrograms per mil. And the fluconazole minimum inhibitory concentrations of 8 micrograms per mil were unchanged in the initial and relapse isolates. And basically, high dose fluconazole in maintenance phase may allow the MIC to be overcome. And alternative treatment may be required, was the recommendation. So I'll just hand back to Manny to go over the management and outcome for this patient.
So the clinical management outcome, as discussed with infectious diseases, we decided to treat her with a maintenance phase of 1,200 milligrams per day for 8 weeks, which is a bit of a higher dose compared to the guidelines, which is normally 800 milligrams for 8 weeks. And then on a continuation and consolidation, we treated her for 800 milligrams per day for a year, or until a CD4 count above 200 and violence suppressed. She followed up at our MOPD about a month later. She was doing well. She was tolerating the high dose of fluconazole. We referred her to a local clinic with a detailed letter, as this is quite a higher dose of fluconazole, detailing to the practitioners at the local clinic to just keep an eye out for side effects of fluconazole. she was doing well and tolerating a high treatment doses, and she had a good psychosocial plan and in place at the local clinic. Akita, over to you.
And just briefly, so essentially in the era before we use amphotericin, fluconazole resistance occurred commonly, as seen in the study at GFU in 2003. It showed that in at least 16 out of 21 culture positive relapse cases, the isolates showed dose-dependent resistance or resistance. Now that we use amphotericin, it is regarded as rare. There we go. And then these authors looked at where the fluconazole resistance had emerged in clinical Cryptococcus isolates over a decade. And this study from Durham, South Africa, was published earlier this year and compared fluconazole minimally inhibitory concentrations in senior formants clinical isolates from 2007 to 2008 with isolates in 2017. So sort of a decade apart. And they found a twofold increase in MICs over a decade. It is not clear if this is due to exposure to fluconazole in the clinical setting, or possibly due to agricultural practices of using azole fungicides. So we are not sure of the significance of those findings as yet, but it is important to take note of. And clinically, these study findings provided evidence for higher fluconazole dose recommendations in combination with amphotericin B. So just our acknowledgements. Thanks.
Thank you.
Thank you very much to you, Ashita and Emmanuel, for that tag teaming presentation. Graham, would you like to make some comments?
Yeah, thanks very much, Akita and Manny. I'll keep my comments brief, just to pick up on 2 points. Firstly, we just wanted to make people aware of the AMBITION trial that this patient was enrolled in. That's now is the largest ever clinical trial done in cryptococcal meningitis. And it's a non-inferiority trial testing a novel regimen, which is one single high dose of liposomal amphotericin B, and then a backbone of fluconazole and flucytosine for 2 weeks. And there's good phase 2 data to show that regimen clears the CSF of a cryptococcal organism as fast as our conventional regimens, as well as animal data that shows that the liposomal amphotericin B concentrates in the CSF and actually stays there for over a week. And of course, this would be a game changer if it's shown to be non-inferior, because you get rid of the toxicities of amphotericin B, and it also becomes scalable in many African countries where amphotericin B isn't currently available. And just on the AMBITION trial, to really acknowledge the study team and the colleagues at Mitchell's Plain and Khayelitsha Hospital who really supported the trial and the conduct of the trial. On the issue of fluconazole resistance, as Akita pointed out, we saw a cluster of cases around 2003 to 2004 at UST Hospital that we wrote up. And those patients had much higher MICs than the one presented today, often up to 256, and was in the context of using fluconazole from the front without any amphotericin B, as we used to do in those days. But it's become a far less common phenomenon and reason for recurrence. So these cases are actually rare. And the most common causes of relapse of cryptococcal meningitis are patients stopping their fluconazole or IRIS. In this patient, obviously the MIC wasn't that high, but the patient was still culture positive with symptoms, responded to reinduction therapy, and had a good history of adherence. So, I think that the fluconazole dose of 200 just wasn't enough to overcome this moderately elevated MIC, and that was the cause of the recurrence. There might have been an IRIS component, but the major issue was the fact that there was an elevated MIC. I've asked Nilesh Govender. Nilesh is an honorary professor in microbiology at UCT, and also head of the Center for Healthcare-Associated Infections, AMR and Mycoses at the NICD, and was the senior author on the paper that Akita mentioned about the increasing fluconazole MICs in South Africa. And Nilesh can just maybe speak to some of the issues with regard to MIC testing. It's not straightforward.
So I'll make 3 points. The first is just to talk about the mechanism of fluconazole resistance in Cryptococcus neoformans. So I think it's really interesting to realize that basically heteroresistance is very common in Cryptococcus neoformans populations. So that essentially means that within a population of cryptococcal neoformans cells, a proportion around 1% are going to be resistant, and that's mediated by duplication of the fungal chromosome 1. And as a result of that duplication or aneuploidy, you get increased expression of ERG11, the target, and also AFR1, which is which codes for the efflux pumps. So essentially, you may have a subpopulation that's resistant. With exposure to fluconazole, you can get expansion of the resistant subpopulation. In some instances, you may just get de novo resistance without a heteroresistant population initially occurring. So the second thing I want to mention is the definition of resistance. And so we use in the laboratory an MIC, which of course you know is an in vitro measurement. And the MIC is either measured using a broth dilution method or an E-test method. I won't go into the details there, but just to mention that the MICs may vary depending on the method you use. The isolates that we test in the laboratory also lose their resistance. This is an unstable phenotype as you passage those isolates in the laboratory. So generally, when I interpret MIC results, I look at a couple of things. The first thing that Kita mentioned is looking at the MICs between the initial and relapse isolate, and here it was unchanged. The second thing is to look at the epidemiological cutoff value, which is the sort of the upper limit of the wild type population. And for non-typed cryptoneoformans, that's 16. So this particular isolate had an MIC of 8, so that's lower than the ECV, suggesting it's wild type. And then the third thing with regard to choosing an appropriate antifungal regimen is then to look at the PD parameter, which is AUC of MIC, and with fluconazole, that's roughly approximated by dose over MIC. And then you can look at the probability of target attainment. So for this patient, obviously dose escalation was chosen for a higher dose of fluconazole, getting you to probability of target attainment, fairly good probability. But then the other options for treatment would be amphotericin B and the other azoles. And then just to mention lastly, that there are a couple of oral drugs in the pipeline that may be useful for, in the context of resistance. Encochleated oral amphotericin B, the new class of azoles, and also some other entirely novel agents such as fosmanogepix. Thanks, Graham.
Thank you very much, Nilesh, for those very helpful comments. And I'm delighted you are able to join this platform in the department. I wonder if you can comment on the laboratory approach to differentiating relapse from reinfection in cryptococcal meningitis.
So that's a really good question. Essentially, the only way you would be able to distinguish a relapse from a new infection would be to genotype that isolate. And so you saw from the report that we didn't do genotyping. We essentially just did phenotypic identification. We have done a previous study. You can either do, you could do genotyping using whole genome sequencing, or you can do MLST, which is an abbreviated molecular technique. And so we've done a previous study where we found that roughly 10% of cases of recurrent meningitis were actually caused by an entirely new genotype. So, I mean, that's a really good point. It's not always going to be exactly the same strain.
Thank you. And Graham, I have a question for you around the clinical approach following the resurgence of symptoms, deciding to treat with a higher dose of fluconazole for a year instead of 8 weeks?
Yeah, you know, I think clearly that she had relapsed on reducing the dose to 200, and there was this elevated MIC. And so, you know, the decision was that we would not go back to that dose again. Whether we could have got away with 400 for a year, it's possible, but I didn't want to take a chance. And as Nilesh said, you know, there is the option of other strategies such as weekly amphotericin B, but our experience with that is that patients find that very difficult, and that they often, you know, adherence is not maintained. So you would try and get away with a higher dose of fluconazole, and one doesn't want to kind of take any chances of a further relapse or driving, you know, resistance more. So I rather went at that higher dose. And, you know, those doses are well tolerated. You know, they've been used in other fungal infections, and they've been used in some trials of cryptococcal meningitis, and without high risk of hepatotoxicity, you know, which might be the concern, but it hasn't been shown to be the case.
And perhaps a final question for Akita or Emmanuel. We see not infrequently these persisting symptoms in patients with cryptococcal meningitis. And what's the mechanism that drives persistence of symptoms?
Well, from in my experience, often it's the organism, the Cryptococcus neoformans, that blocks the choroidal plexus, and that can drive persistent raised intracranial pressure, and persistent, even with treated cryptococcal meningoencephalitis, the organisms of this, or the fungus, blocking the choroidal plexus and the flow of CSF. This raised intracranial pressure. So even though they've been treated, you'll find after 7 days they might still need lumbar punctures because they have raised intracranial pressures. Yeah.
Thank you very much. I see there's a hand from Ian Ross. Do you have a question, Ian?
And Tobeka, no, it was from the previous discussion. Thank you. Thank you very, very much.
Well, it's a great pleasure for me to bring today's meeting to a close, and I'm sure you'll agree with me. Again, an exceptionally high standard of presenters, and I'm grateful to all of them and for everybody who contributed to the discussion. Take good care. Bye.